Premalignant bowel lesions are abnormal growths in the bowel that have the potential to progress to colorectal cancer if left untreated. Identifying and managing these lesions early is critical to preventing cancer development. Here is a detailed explanation of the types, causes, diagnosis, and management of premalignant bowel lesions. Types of premalignant bowel lesions. 1. Adenomatous polyps, adenomas. These are the most common premalignant lesions in the colon and rectum. They arise from glandular epithelial cells and are classified into tubular adenomas, small and less likely to become cancerous; villus adenomas, larger, finger-like projections with a higher malignancy potential; tubulovillus adenomas, a mix of tubular and villus features with intermediate risk. Dysplasia is commonly seen, which indicates abnormal cell growth. Number 2. Sessile serrated lesions, SSLs. Flat or slightly raised lesions found predominantly in the right colon. They have a serrated, sawtooth-like histological pattern, more likely to progress to cancer through the serrated pathway, often leading to microsatellite instability, MSI cancers. 3. Hyperplastic polyps, generally considered benign but can be precursors to serrated adenomas in specific locations or sizes. 4. Inflammatory polyps, often seen in inflammatory bowel disease, IBD, like Crohn's disease or ulcerative colitis. Chronic inflammation increases the risk of dysplasia and cancer. 5. Hamartomatous polyps, associated with genetic syndromes like Peutz-Jeghers syndrome and juvenile polyposis syndrome. Although they are benign, they can predispose individuals to colorectal cancer. Risk factors for premalignant lesions. 1. Age. Incidence increases with age, especially after 50. 2. Family history. A history of colorectal cancer or polyps increases risk. 3. Genetic syndromes. Lynch syndrome, hereditary nonpolyposis colorectal cancer, HNPCC, familial adenomatous polyposis, FAP. 4. Lifestyle factors. Diets high in red and processed meats and low in fiber. Obesity, smoking, and alcohol consumption. 5. Inflammatory bowel disease. Prolonged inflammation can lead to dysplasia. Diagnosis of premalignant bowel lesions. 1. Colonoscopy, the gold standard for detecting and removing premalignant lesions, allows for direct visualization and biopsy of suspicious lesions. 2. Histopathological examination, determines the type of lesion and the degree of dysplasia. 3. Fecal tests, fecal immunochemical test, FIT, or fecal occult blood test, FOBT, can detect blood from lesions. 4. Imaging, CT colonography, virtual colonoscopy, may identify larger polyps. 5. Molecular testing, tests for genetic mutations in lesions, such as KRAS, BRAF, and MSI status, can indicate malignancy risk. Management of premalignant bowel lesions. 1. Polypectomy, removal of polyps during colonoscopy, endoscopic mucosal resection, or endoscopic submucosal dissection. 2. Surveillance, follow-up colonoscopy at intervals depending on the size, number, and pathology of the lesions. High-risk patients, e.g. with multiple adenomas or genetic syndromes, require more frequent screening. 3. Preventive strategies, lifestyle changes, healthy diet rich in fruits, vegetables, and fiber, regular exercise and weight management. Chemoprevention, use of aspirin or other nonsteroidal anti-inflammatory drugs, and NSAIDs in high-risk individuals, e.g. Lynch syndrome. Prophylactic surgery, considered in conditions like FAP to prevent cancer development. Prognosis. Early detection and removal of premalignant lesions significantly reduce the risk of colorectal cancer. Regular screening in high-risk populations is crucial for favorable outcomes. Premalignant bowel lesions are a critical focus of colorectal cancer prevention programs. Advances in diagnostic techniques and screening strategies continue to improve early detection and management.